Yeah, a little about me. I think, as Kaushik has rightly mentioned, joined Care organization a couple of years back, and then I was in UK for a few years, and then I did my masters, and then I did my specialty in musculoskeletal oncology, that is cancer orthopedics, and then moved back to India, and then started my career with Care. And yeah, Care is one of the excellent medical facility available in Hyderabad, especially the hospital what you see on the screen. It is from Banjara Hills. We have a couple of branches in our city. So this is one of the largest, flagship branch which has state of art facilities and robotics and everything. That's what we do here. So our department is a huge department, and we have more than 15 orthopedic consultants, and then each member has their own teams, and then we lead the teams. And then from my team, we have another four consultants, and then we work as a team together, and then we do multiple specialities, like right from joint replacements to cancer orthopedics, sports medicine, like arthroscopic surgeries, and also spine surgeries. And regenerative medicine. So today we will discuss basically about two most important topics, that is joint replacements and also regenerative medicines, because these two things needs a lot of focus all over the world. We know that people are doing joint replacements, and the outcomes are changing from person to person. However, just what we do differently is what I'm going to share here. So can I just change the? Okay, great. Okay. So the topic, I named it as advances in orthopedics. So let's go ahead. Yeah. Next screen, please. Yeah. With changing trends every day around the world, and technology and precision are key to good outcomes in surgeries. I'm sure everyone agrees with this point, because every day we are getting something new. Every day we are talking about robotics, navigation systems. We are talking about artificial intelligence. So there's so much so is coming into our field. And is it really good to adopt to them, or is it bad, or shall we wait and watch? There's a big question mark. However, I think as an orthopedic surgeon, one must be well versed with the systems what are available. Whatever, there may be hundreds of robots coming, but one should have a basic idea about one system at least, so that you should not be in the back bench saying that no, we don't know about that. So the whole idea is that so adopt to the technology and then use it very rightfully. So orthopedics is something evolving much faster than any other branches due to its vast exposure and sub-branching out. However, as surgeons, we must always focus on good outcome with time-tested approaches and combined with technology. So this is always what I tell my colleagues and juniors, that we must know the technology, but just straight away don't use the technology just because you know about something and then on the patients. Because if you see, the robotics surgeries are also failing largely. There is an NHS data which has recently been published, saying that the clinically there is no much outcome difference in terms of robotic surgeries versus non-robotic surgeries. So there's a lot of data which is still coming, but however, I would not take any sides here, but I am just urging everyone that we all must adopt to the newer technologies. For that, one has to have good hands-on experience with changing trends and must be well versed with the approaches. Yes, so the approaches, as I said, that we must know. At the same time, we must also decide. Judgment is right judgment. What is the best you are able to give to your patients is the key here. So hence, learning never stops and it must go on. Next slide, please. So what's new in joint replacements? Joint replacements. I'll be taking questions after my Zoom session. Then we can probably have discussion. So now I'll continue just to talking about the slides what I have prepared for you guys. So joint replacements are the most widely done surgeries across the globe by orthopedicians. There's close to around 40 to 50,000 joints happen across globe, if I'm not wrong. So there's a study on replacements done by various surgeons have varied results and why. So I'm sure we all have our orthopedic colleagues, and then some surgeons may give good outcome, some surgeons may not be able to give good outcome. Some surgeons, even though they have good experience, sometimes they end up not giving a proper outcome. Why is this difference? I mean, we are all orthopedic surgeons, we all are doing joint replacements for many years, and why are we not giving this 100% quality surgery to, I mean, why is not standardized basically? So because we are dealing with humans, and each patient presents with the different varied presentations, and then some with varus, some with valgus, some with multiple grade with ligament imbalance, some with, so multiple issues we deal with. So we all have to understand that what exactly is patient's demands. Sometimes we see grade 4 arthritis with with bony defects. People will expect 100% outcome, and they want to do so. The expectations of the patients are also the key. So we have to first, pre-prepare ourselves by templating the X-rays, and then we should understand needs of the patients, and then usage of well-balanced implants with availability of multiple ornamentarium. What I meant was ornamentarium is most of the times we think that we can get away primary knee replacements with, or primary hips with just the standard, implants, but then we sometimes end up taking excessive cuts, and then excessive bony cuts, and then we may have to not rely on the epimetaphyseal load. We may have to go for diaphyseal loading implants. That's when we use these extended stems or intramedullary rods to give additional stability to the joints. So basically, pre-templating gives us all the idea about how. So in our facility, we make sure that all the X-rays are pre-templated, and then we discuss at least a day before the surgery that what is it that we are going to need on the OR. So you would see sometimes we have more than 30 to 40 boxes of implants just in the OR corridor, because we don't know what we may need, and then we keep all the backup. So there can be one surprising case, there can be one bad case which can really, demoralize you. So we make sure that, all the ornamentarium is available to you. And then secondly, I also say that how many of us are well trained in the above, and how important is to track the outcome. There's still a lot of confusion on to use robotics or not. So, talking about technology, how many of us have robots in our institutes? How many? So, I'm working with a corporate. I'm okay, lucky or blessed to have a robot. Not one. There are 3 to 4 robots in our institute. But many organizations don't have robots. Many surgeons don't get hands on doing the robotic surgeries. So, do you think a robotic surgeon can do better than a normal surgeon? I don't believe that, because I think the classically what have been done for so many years, and there's a huge data, as I said that just now in the previous slide, that there's no much difference between the outcome. However, we must also have hands-on training with robotics, so that we are future ready for that. So robotics, what my experience is, see, I think first used the robot in 2010 or 11 in UK. That's when the first robots have already started the Mako. Uh, those days it was very, what do you call that? The robotic role was very, very low. All you have to do is just to take the arm and then just, place it. We used to use a navigation system. Striker had the navigation system, and then, used to use navigation, and then they just mechanically the hand, I mean the mechanical hand, the robotic hand used to do the cuts. So that's the only job, limited job. And then there used to be a lot of what do you call, pre-preparation of the patient. You have to put multiple tracker points, and then followed by you have to feed the data into the system, and then once the data is fed, then you have to start doing the procedure. And the surgical time also is I mean longer compared to the normal nowadays. But people do claim that robotic surgeries are much shorter. They say that within 45 minutes they're able to complete the surgery, but I'm still not very comfortable making that statement. So robots will take time, and then it adds a lot of stress onto the bone, because we use multiple tracker marker pinholes, the femoral end and the tibial end. So these are stress risers, and then they may cause periprosthetic fractures eventually. Yeah, next, please. So, so at our facility in care, the robotic surgeries are selectively done and using navigation to do cutting edge joint surgeries. The reason why I'm selective, I'm saying is sometimes it's also the patient's demands. Sometimes patients have something particularly in mind. A large, I mean, India like country, when there are so many specialists are available, patient always has a choice to, go to, any other robotic surgeon and say, I want a robotic surgery. So, however, we have to use our consciousness and explain the patient, take your time that whether the patient really needs a robotic surgery, whether it is going to help, because it's hardly going to add any additional value. However, the minute differences also can make sometimes large difference. So we counsel the patients and then we explain them, and we also tell them that the outcome is going to be like this. So counseling is the key, and also at care we are doing these fast track joint replacements. Many of you must be aware of these fast track joints. Fast track joints also I started doing in the year 2014. So the patient is basically staying in the hospital only for one day, and then the next day patient is able to go home. So how are we achieving this? So there are various ways that you do a fast track knee replacement, minimally invasive. So our approaches are slightly different. Instead of using a midline parapatellar approach, we use subvastus approach, where your quadriceps strength is retained, and then we are using selective regional block anesthesias. That's we are giving adductor block, and then we are giving femoral block. We are also giving intra-articular blocks. So mostly the surgery is done on blocks, and sometimes we use tourniquet, sometimes we don't use tourniquet. So but then that so basically these approaches matter a lot, because patient the reason why patient is not able to walk very next day is your prolonged anesthesia, that is epidural or spinal anesthesia, which will hamper your mobility. So by reducing the spinal load, by giving more regional anesthesia, patient is able to tolerate pain much better, and then we are mobilizing them. These are called fast track knees. We are doing for almost every knee nowadays. I think our turnaround time, patients staying in the hospital is not more than 2 days. If someone really want to stay for another day so that they don't get proper care at home, they're staying for 2 days. Otherwise, usually in a day we can. And our fastest recovery and rehab, say like within 4 to 6 hours, I made my patient walk just 4 hours after the surgery, and then from OR room to the room, patient room. So this is possible if you have a good supporting team. And also the implants. I think the key note is here, the implants. What kind of implants are we using? Are we So there are so many implants. There are so many evolutions happening with every company. So by far, I think now the what we have in current trends is a high flex, ultra high flex, ultra congruent knees. These ultra high flex, ultra congruent knees, you all must be aware. There are two types. One is the PS knee and the other one is the CR. Hello? Yeah. Hello? Yeah. So these implants, choosing these implants also is a key. So we are lucky to get various implants from various nations. We are getting mostly from Europe, Switzerland, from Italy. We are getting implants, and we are getting implants from America. I'm getting implants from England. So all the companies are available in our city, and then and they're all standby usually. On sometimes we take a decision on table that we may tend to change the implant. So high flex ultra congruent knees are the way, and then various metals are available now. We see oxynium, cobalt, chromium. Now oxynium is the thing, and then also ceramic knees have come. All ceramic uncemented knees have come. We've done one or two, but the outcome is still awaited. It's a bit scary to still talk about it, because uncemented replacements to the knee and that to all ceramic, it's with this thing, but beautiful implants, that such precision cuts, it's like, just like a robot, you can make cuts, and then you don't have any cement mantle in between the bone and the implant. So even those are available. So basically to have good implants, and then we are always stocked with all the possible implants on the table. Yeah, next please. So, right place, right surgeon, and most importantly, the affordability of the healthcare. So, for a patient, I think the biggest factor driving a patient to the hospital is the reputation of the hospital and the reputation of the surgeon, and also the outcome, and also it should be affordability. I think we are focusing morely on the affordability of the healthcare. So if you look at, I'm right now in Europe. I mean, just talking to someone, it is so difficult for them to get a appointment to a specialist. But in India, it's so easy that you have specialists available round the clock, and then you have accessibility to them, highly trained, highly skilled, because most of our consultant surgeons are trained, and then all from various parts of the world, from the best of these institutes. So that's how I think that's what matters. And then affordability, as I was talking to, when I compared especially with healthcare in terms of certain procedures in India, Hyderabad, to rest of the world, I think I must say we are, I think, the lowest, including I compared with Sri Lanka. In Sri Lanka is a small tiny nation. I found that the joint replacements cost close to per joint around 8 to 10,000 dollars. That's huge. I mean, I think in US it costs around 20,000 to 25,000 dollars. In Europe, it costs around same 15,000 euros. In UK, it costs around 14,000 pounds. So it's like, so if you compare to all that, I think we are able to do the top quality, finest implants with robotics around probably maybe 5,000 to 6,000 euros. So that depends, that varies. So basically, I'm comparing that it is we are at 50% lesser compared to any other world over treatments. So then also we wanted to build this long-term relationship with our partners and patients. So we have actually a program that, once a patient, so if you see most of the places, once the patient surgery is done, then patients walks away from the hospital, and I think it's almost impossible to connect with the, surgeon or consultant again. But we wanted to maintain this chain, of relationship with them till the time they're completely rehabilitated and they're almost, able to do everything. So we maintain a communication system, where we are constantly checking their mobility, constantly checking their needs, and then, addressing their problems. So that's how I think patients will get confidence on the doctors. So, I mean, I talk to every day at least 2 to 3 patients from all over the globe, wherever my patients have gone, and they talk to me. They send me their reports, and then they send me their queries. So, I keep addressing them. So that's how they feel comfortable, because some third person speaking and then doctor themselves speaking to the patients always matters a lot. So it's a multidisciplinary approach. It's not like one man show. It's just me. I am doing everything. It's never like that. There is a huge team, and imagine my hospital and our international team. And every day we have more than hundreds and hundreds of messages of communication. We ensure that patients are constantly being informed, and then so it's a teamwork. I would always say. Then our teams are always helping out with the patients and their needs. So basically, we also engage in these education programs. Recently, we started something in Africa where we started training the young doctors there with certain newer techniques, so that they are also future ready, because learning traveling is sometimes maybe very expensive. Most of the places they don't offer free learning and free education, so you have to pay at least for your accommodation and travel, and all these things they are very expensive. So we wanted to extend our whatever little knowledge we have gained, and then we wanted to share our thoughts with the region doctors, that how we are doing, and how we are doing differently, and how our outcomes are. So we are having a sharing. We have started these platforms to train, and then we are also inviting some doctors to our facility to join us to ours, and then see what's happening, and then how do we do. So that's how I think we are engaging ourselves. Next, please. So other topic what I was just about to discuss is regenerative medicine. What is regenerative medicine? Many of us must be wondering what is this new terminology. Regenerative medicine has been there for quite some time. So I finished my MBBS in 2007, and then that's when we actually started doing these PRPs and all these injections. So people don't have much awareness on those things, but then we do have a data that platelet rich plasmas has a very good regeneration capabilities, and used in the right medium at the right places. So we almost forgotten the techniques of regeneration. God's kept best secret is power of regeneration, don't we? I think we all get healed up if we just provide the right environment. So regenerative medicine focuses on tissue regeneration by using natural methods to avoid unnecessary surgical exposures. There is a huge data published recently. There were almost 20% of the global surgeries done by orthopedic surgeons were not needed. So needed, I don't know why they made that statement. Needed means probably the time of incidence of surgery could have been delayed, or it was not the right surgery meant. So whatever, I think so. We always have to give initially multiple trials to the patients to ensure that they heal, whatever the problems are solved with non-surgical exposures, basically. So try with medications, try with these kind of alternate medicines, try with regenerative medicines like PRPs. So what are the alternate medicines and regenerative techniques we have available? Is PRP is just now I discussed. This is platelet rich plasma. We are doing about I have done around 3,500 PRP injections in the last 3 years. Believe me, they worked well, and then they are doing wonderful. So these were all mostly younger people who are below 40, below 50, who wouldn't need a knee replacement. Even though there was a need for them, these injections will delay the incidence of surgery by improving their quality of life. So as in our profession, I think what we must know is what is our job is to treat the pain. So if applied these kind of medicines, I'm sure people will have good effects. So next is ACI, autologous chondrocyte implantation. Many of you must be doing, and then stem cells. So we have in India no legal bounds on practicing stem cells, but many countries have stem cells band. Then we have BMAC, that is bone mineral aspirate concentration, concentrated fluids. So we'll discuss briefly about them. Kindly share change the slide. Yeah, PRP. What is PRP? Is platelet rich plasma. There's a lot of confusion and controversy on this topic. As I said that I've been using since 15 years, and many across the globe are using. Even in US, they are using these PRP injections. So everywhere they are using these injections. It's a very simple injection. Basically, 25%, 25 ml of blood is being drawn from the patient source, and then it is centrifuged in a growth factor environment for 15 to 20 minutes. And then followed by you get platelet-rich plasma, and then we'll be injecting into the affected joint. So we are using basically for early degeneration like arthritic changes, knees, shoulders, hips, and also in avian conditions, these PRPs are used. Sports injuries like ACL tears, meniscal tears, rotator cuff injuries, ankle injuries, and also tennis elbow and sorry, not spelling mistake was there. It's a disc herniation, not discus herniation. Disc herniation, especially in the spine, IVDP, early changes, grade 1, grade 2 disc bulges. You hydrate the disc by just injecting some, PRP into that. These are all conditions where we can use PRPs, and then they are helping. I may publish soon a data on this. Uh, so this is my personal experience. They are doing well. Next slide, please. Other regenerative techniques what we use in our facility are ACI, that is autologous chondrocyte implantation in knee arthritis, where your articular surface are damaged. So we take the tissue from elsewhere and then we implant it back into the thing, into the joint surface, and then they start regrowing. And then other one is a BMAC. It is also one of the orthobiologic technique where bone marrow aspirate concentrate is taken and injected in various conditions like tendon injuries and bone vascularity issues. Bone vascularity issues, what I'm talking about is avians. Stem cells, same with stem cells, though there are no clear studies have been published, but widely stem cells are being, at least in our country, in many countries, they're doing it cord blood extraction, stem cell extraction, and some of the conditions they're really doing well. I've had recently one patient who had a chronic muscle dystrophy with muscle tear, I mean, tendon tears in the ankle. So stem cell, we couldn't do the stem cell here, but then he has gone to US and then they've done stem cells. Believe me, he was suffering from last 4 to 5 years, and then you know he is just relieved of the pain from stem cells. So like that, I think there are many ways. We are always, in search of trying to improve our quality healthcare by adopting to the most conservative treatments first, and then followed by we are planning their life for the future. I think as a doctor, as a surgeon, we all have to decide what's best for our patients, and that's how we plan for their future outcome. Next, please. Conclusion. Yes, the whole presentation is about how changing trends in orthopedics are helping and reshaping healthcare in the world. So this is about our facility, which has a strong team of surgeons who are constantly evolving with the changing trends and updating our knowledge and applying it thoughtfully to our patients to ensure highest care is given to the patients. Our healthcare programs are most affordable by any means globally and spreading our wings to many nations. We are happy to, you know, serve many nations from Africa, from Asia, and we get so much of load from these countries, and then we are sending them, we're giving happy results to all the patients. So I think that is it. Any questions, please, you can ask me. Thank you very much. So last slide, please. A small. The more you learn, the better you will be able to make decisions about the direction of your life. So I like this, words because they mean a lot. So the more you learn, and then they'll make you a perfect decision maker. And we all as surgeons, the more practice we do, and then I think we learn with our practice and we learn with our time and experiences. Okay. Thank you very much for giving me this wonderful opportunity, and thank you, Care Hospitals, my hospital, and our counterpart from Cambodia, and everyone for helping me to go through this. Any questions, please?
So for the PRP injections, what stage of arthritis can be given, and among the PRP and stem cell, which one is the better outcome?
When it comes to PRPs are very, very inexpensive. PRPs don't cost more than $100 in our setup. So it's easily available, and then instantly you can start giving. Whereas a stem cell is a more expensive process and then more painful process compared to the PRPs. So I think basically for early degeneration, PRPs still work good. So stem cells, if some defects, especially some defective conditions where large articular defects are there, we are dealing with in a very young age where we want good results to be there, then stem cells are useful there. So it is subjective again. We don't straight away do stem cells to everyone. And PRPs are usually given one injection once in 6 months to 1 year. Hello?
Yes, sir, we can hear you.
Yeah, I'm waiting for questions.
Okay. Dr. Chandarit, you have any more questions from the group?
They have the question in the group. PRP injection, you have the drugs injection for knee arthritis, example supplement. What?
We'll read it out. First question is, what are
Yeah,
the
I
natural?
got this point. Yes. So the PRP injections are just not only PRP. It is a cocktail combination. There's a lot of confusion that only what to give. So PRP we always combine with local anesthesia, and also we give hyaluronic acid, that is jelly. Someone rightly, I think it's we call it jelly. It's basically lubricating the joint. Hyaluronic acid, highly cross-linked hyaluronic acid. So these are the combinations which use. Call it as a cocktail combination, and then this cocktail combination really works well. It's never alone PR. What are natural methods of regeneration we should eat? Okay. So naturally, the thing is weight management is the key, and avoid eating sour foods. So and then don't strain your knees too much. I think with changing age, one must adopt a healthy lifestyle. If you are crossing 40, I think one should maintain a good healthy lifestyle. Avoid climbing stairs too much, avoid straining your knees, and then eating fiber rich food is the key. Avoid eating red meats, and also avoid eating sour foods like processed and canned foods, what I meant. So these are the foods, and the natural foods, as I said, that can have fruits, fiber rich food, and some basic healthy exercise for your muscles. So static quadriceps exercises. So these exercises will keep your joints supple for a longer time. Wonderful. Yes, yes. I think, we are having plans to visit your beautiful country very soon, and then we will have a training session on how to do PRP injections for multiple joints. So if we have probably, good volunteers, uh, then we can demonstrate these PRP injections. They are very simple. So we will definitely, you know, want to train our friends the various techniques of giving PR.